So hi again, everyone. It's a privilege to moderate this session. On today's panel, we have the two speakers who you've already heard from. So welcome back, Anne and Zulfiqar. I'd like to thank you both for your excellent presentations. I'm sure they've given everyone lots of food for thought. And then lastly, we are also joined by Dr. Bakri. So Bakri is a medical doctor who also has a master's in public health in developing countries from the London School of Hygiene and Tropical Medicine. And he has a long history with MSF. Prior to his current position, he spent many years as a medical coordinator and head of mission, where a large focus of his work has been responding to emergencies in conflict settings. He is currently the health advisor for MSF Ocupa's operations in East Africa. And we're very happy to have him join us to bring this MSF Ops perspective. But we found out that, there's a wealth of MSF experience on the panel. We're very happy you're still active members of the MSF family, Anna and Zulfiqar. So yeah, I think it's going to be a really interesting and fruitful discussion. So please, everyone online, post your questions to the panel in the chat box and we will try and get them answered. But to start with, I'm going to pose a question that I'd like all three panelists to answer. What do you think would be the main opportunities for the humanitarian sector and particularly for MSF to mitigate against some of these negative effects on child health brought on by the Covid-19 pandemic? And I'm going to direct that question to Bakri initially to welcome into the session. Over to you, Bakri.
Thank you so much, Kim, for having me today. And just to answer your question, I would like to focus on three major points I see. I see them as opportunity for MSF to improve, to deliver health services in such situations. The first is, as we all know, the mother and child health programs relied heavily on community participation and continuity of services in the last 3 or 4 decades. And MSF increasingly relied on these community models to deliver health services in our programs. Unfortunately, with this pandemic, communities have been cut as part of the containment measures to curb the spread of the disease. And we, as MSF, also added to this isolation of communities by adapting services and classifying these services as essential that we need to continue and non-essential we need to adapt or modify. Unfortunately, most of the health promotion and community engagement activities were required to be adapted. So I think we added to the indirect impact, especially on mother and child health in a way. And I think that deserves a second look on how we classify our essential and non-essential services as well, and the criteria that we rely on. The adaptation measures added more responsibilities to the communities. For example, taking the family MUAC example, we trained mothers who are not part of the health system in the past, and now we added more responsibilities on them. Accountability issues came as well. And all this happened without providing or without having the opportunity to provide them with the necessary support. So I think that posed a big challenge for us, as White Nile project mentioned. This lack of this isolation of communities, lack of support, also removed the purpose and of having these community models. Like, for example, the equity. It wasn't there anymore. The tailored support or the tailored services we provide according to the need were not there anymore. The supervision were not there anymore. So I think this point needs a second look on how MSF engage with communities. And also we need to re-examine again whether these community-based packages provided autonomy to these communities or not, especially in the context of these pandemics. Second point for me is the monitoring of disruptions and addressing those disruption detected. Again, if I would like to take example of White Nile, we detected this through the official HMIS. The notification and the alert didn't come from the community itself. And that was, for me, it's a warning sign. We designed a project based on the community, but the warning didn't come from the community. It came from MSF as well. So also that's, for me, a warning sign. The other point is the evaluation of the impact. And I'm very glad that Sierra Leone mentioned this. The types of evaluation we follow in MSF are mainly to measure the outcomes, but we don't have any kind of embedded evaluation mechanisms within the projects, within the communities, to measure community-based activities. And I think now the type of evaluations we need is more to capture the contextual change, is more to capture the deviation in the implementation and the problems of the implementation. So I think also MSF needs to look into the type of evaluations we follow in our projects in a different way. I don't think outcomes evaluations are suitable anymore for the type of interventions we do in our programs. My last point would be collaboration with other actors. And for the third time, I will take White Nile as an example. One of the challenges that were mentioned by the project during the implementation of the family MWAC was convincing the communities, convincing the community leaders, but also we faced some resistance from some of the agencies and organizations in implementing this. And I think at that time, we went back to ourselves discussing the possible impact on our plans to implement and roll out the family MWAC, rather than engaging in a wider discussion with these agencies to remove this resistance. So I think also we need to be more external rather than internal in our discussions with the other humanitarian actors, with the other part of or the elements of the health systems. So I think these 3 points for me poses the big challenge we faced during the adaptation of activities during COVID. And I think all these 3 points affected indirectly the services we deliver, especially the services towards mother and child and children as well. Thank you.
Thanks, Bakri. That was a really comprehensive overview of the way MSF has in some ways contributed to some of these issues. Zulfiqar, would you like to add any comments on this question?
Well, I mean, I think Bakri has covered most of it. I think there are tremendous opportunities for identification of populations which are at special risk of COVID-related impacts. So I'll point out the need for an equity focus in the responses, which is also dependent upon data and information that allows you to track and test where these cases are and where these impacts are maximal. Most people recognize equity dimensions as very broad measures around socioeconomic gradients, but unless you know where the people are, it is very difficult to act accordingly. So we are increasingly moving to much more geospatial location and localization of pockets where interventions may be needed and are necessary. So there is a case to be made for better data systems. But the other important measure that we need to have in responding to what is a clear impact in the direction is to avoid that in the future. So I think the biggest learning for the humanitarian sector, for people like MSF and others, is what can we learn from these recent pandemics in terms of trying to do better next time in our guidelines, in our field operations and procedures. So some of those are being aware of the needs and requirements for many of these families and children, and putting things in place that can, in those settings, maximize what you get from particular contact points. So I think had we known what might happen at an early stage of this pandemic with the reduction in antenatal care and access to primary care facilities, we could have modified those guidelines for contact points to maximize the amount of information, the amount of commodities and materials given to women so that they did not run out before they had an opportunity to come back again. The second is much more reliance on mobile services. if people are not going to be able to come because there are no transports available and there is a restriction on movement, then one could have put a lot more outreach services and mobile services in place. And the third and final thing that I would say is that if we've learned anything from this pandemic, is the vital importance role of community health workers. And in many regions, including even in urban slum populations, having these outreach community health workers who have not only tacit knowledge of the communities where they work in, but can be task shared to provide many things that otherwise would not be possible, has been a saving grace. So those things we can do as a community moving forward.
And thanks, Zulfiqar. That was a great answer. And lastly, Anne, do you have any further comments to add on this point?
Well, I just sit back and really see that children are paying, right? They are paying the price of this pandemic in so many ways. And what my worry is that, we've seen the effect, the collateral effect of the pandemic itself. But I think that we need to be even more mindful now with the COVID-19 vaccine rollout collateral damage. Because the amount of healthcare workers that actually is needed to be able to deliver all these vaccines is going to push away even further the already damaged services that we see, and the children are paying the prices. So I don't think the world will ever forgive us if we are only one-eyed about ending this pandemic and rolling out the vaccines without really seeing that strong link into the maintaining and restoring the vaccines, the vaccinations and the services that we have. What I think for MSF is that, well, first of all, you need to continue to focus your excellent medical humanitarian services and focus them, reach those that needs to be reached, maybe be more efficient in services. So giving out integrated campaigns of immunization, for example, and multiple services, integrated services at the same time. One thing that I think is not so much needed I wouldn't say this early on, but now I wouldn't say that as much. The advocacy arm of MSF is one of the most powerful. The access to vaccines, there are many people out there on the access and equity advocacy side for COVID-19 vaccine, not the least COVAX itself. What MSF could do is rather be that strong advocacy voice for maintaining services, for the primary healthcare services that needs to be upheld during the pandemic. You see the damage that is being done, and you have the strong voice around to be able to raise the voice of MSF and hold people accountable for continued services. I think that it could be very, very, very key. There will be competing priorities, and not the least in Q3, Q4 of 2021, when there will be hundreds and hundreds of millions of doses being rolled out of COVID-19 vaccine. That's the time when we need to be really, really mindful. So we can course correct kind of now and change the efforts that is being put into maintaining and restoring the immunization services and the primary healthcare services. Yeah.
Thank you very much, Anne. And we have a couple of questions from the audience related to vaccination, and you have touched on some of these already. But one of our questions is about the ethics of suspending vaccination campaigns for other diseases, such as measles, to prevent the transmission of COVID. And what can MSF do to support ministries of health or other actors to help maintain routine immunization programs or mass vaccination campaigns? And Anne, I think it's logical that you answer that first.
It's clearly unethical not to immunize and not to try and reach and uphold as you saw my graph, That's the main worry. I'm really worried that we're going to get measles outbreaks in the middle of the COVID-19 vaccine rollout in the fall. I mean, we have an immunity gap. We've seen it. And unless those children are being tracked, and that is really the tedious work of going, village by village, house to house, and knock the doors and restore the campaigns when they're needed. Maybe do it more efficiently, maybe reaching with many antigens at the same time, as I said, So I think the ethics here, there is no ethics. You can't push away measles. Measles will come back as a rocket if you do not keep up the immunization. It's the first one that signals a decrease in immunity, and it will be signaling to us very soon, I think, in communities that are the most underserved, in those communities that we discussed, that I showed, the zero-dose communities that are lacking not just the measles vaccines, but many other services at the same time. So I think that we need to be very, very mindful and restore and restate those immunization services. We have mapped out where those are most at risk. I think where they are in everywhere where MSF is. And I think with the experience of MSF, it's just have a strong focus on going out, restoring and supporting the governments, not to forget about the regular immunization and campaigns that needs to be done to fill the gaps in campaigns, but also to restore immunization services as they are, with safety measures in place so that healthcare workers feel safe to go to those, and so that parents feel safe to go to get vaccinated for the vaccinations for their kids. Yeah.
Thanks a lot, Anne. So our next question, Zulfiqar, we've heard you talk about the impact on adolescents and girls and the risk of early marriage, but we have a question about the impact on child abuse and gender-based violence and other protection concerns. And we would like to hear more about what MSF field teams can do to identify and support these children who might be presenting for another issue. How can we help them?
So certainly, that's a great question. And certainly we know that the whole prevalence of mental health issues and also exposure to mental health problems in adults, domestic abuse, child abuse, all of that has gone up during the course of this pandemic. But there isn't solid data yet on what proportion and where, because these are such difficult and taboo subjects that are generally very poorly recognized in surveys. But in general, from where data is available from services and countries where there is reasonable reporting, the prevalence increase is close to around twofold, if not more. And that has also led to an upsurge in some geographies of adolescent suicides as well. So we are very cognizant of this. I think what it does mean is that even though it may be difficult with the closure of ambulatory services and the focus on selectively children with chronic disorders, that this opportunity should be made available to parents to recognize such risks early, and for other social sector workers, social visitors and health workers who see these kind of circumstances to recognize and protect children from the very get-go. So the answer is yes, those things are there, not very well quantified and not easy to recognize in classic clinical contact, but you should be aware of those in the context of the broader family dynamics. So I would say the violence against children is generally also associated with violence against women. And therefore, these families where there could be an abusive situation or an exposure to a mental health issue is something that outreach workers and those in fixed facilities should be well versed in and able to recognize.
Thanks a lot, Zulfiqar. And Bakri, do you have any further comments about this? Because I know we've been discussing protection a lot in the House recently.
Yeah, I think one of the biggest problems of sexual violence in humanitarian settings in general is detection by our teams. First of all, as Dr. Zulfiqar mentioned, it's a taboo topic. It's very hard to detect or to report by families, putting in mind that some of the perpetrators might be from within the families itself. The other thing is the lack of concrete tools in MSF to detect this type of forms of violence in emergencies. We have only very limited time with different emergencies and assessments to do. And I think, unfortunately, sexual violence doesn't rank high when it comes to the assessment, unlike when it comes to the response. So I think paying extra cautions, extra attention by sensitizing our teams on the topic, training them on how to detect this within the context of regular consultations and counseling is very, very important. And that only comes by time. Unfortunately, within emergencies, there's only limited time to do all these kind of things. So yeah, that's how I see detection, to improving detection.
Thanks a lot, Bakri. We have a question from Neil, and I'm going to go to Anne first because I think she touched upon this briefly when we were talking about immunization. But what can MSF do to speak out more for children, with the notion that we speak out a lot about specific medical issues, but maybe we need to take a broader approach to looking at speaking more about people and specifically children. Oh, Anne, are you able to go next?
Yes. Mm-hmm. I think that is the role of MSF. I think that can be a very strong and very needed role for MSF now. Be out there and speak and say, you don't forget, don't be blind, don't look at only immunization, the pandemic response and the rollout of the COVID-19 vaccine. I think that your voice is actually needed. It is needed. I mean, Zulfiqar's scientific voice is also needed, but translate his data into your advocacy machinery for the right of children here. Children are paying the price. I think that was good what you said, Zulfiqar. They're not the face, but they're the victim. So the balance between, we're trying to stop this pandemic. We all need to, right? But not at the expense of children's lives, of maternal lives. And now you have the data of Zulfiqar from South Asia. Use it and speak. You can talk about your programs, just like you did here in the previous session. I think the voice of MSF is definitely needed.
Thanks a lot, Anne. And we have a question for Zulfiqar about how, whether you could say something about how generalizable the findings are from your presentation on South Asia to, for example, another low-income setting, such as a sub-Saharan African setting where MSF has the bulk of our operations. What do we know about sub-Saharan Africa?
So unfortunately, not much, because data collection and general systems has not been as robust, but we have many countries collecting DHIS data, and generally the trends in terms of what happened with early stringent measures are in the same direction. In general, Africa has had much lower population testing rates for COVID-19 than other parts of the world, and with the exception of South Africa. And a big reason for that is cost. I mean, these are expensive tests, and they're mostly reliant on imported kits. And therefore, to expect that you'd be able to do several thousand per unit population of some sorts is just beyond. I have seen this myself, that we've been asking countries to divert millions of dollars of their precious resources to just testing alone. So there hasn't been a rationale for doing this over a period of 12 to 15 months as we have been doing. But that does not mean the disease isn't there. Just the fact that we don't have COVID positivity doesn't mean the disease isn't there. And I think also very importantly, we should expect that the direction of effect, even though the severity may not be as much, may be in the same direction. So in our systematic review, there were quite a number of studies from Africa, but they were not as large, and they were generally from major teaching centers. So my roundabout answer to your question is, it is not clear at this point in time if the lower prevalence of COVID-19 in Africa is a function of just poor case classification and testing that does not allow us to allocate a particular deaths to COVID or otherwise. And it also is partly the fact that even though there may have been large number of cases in certain countries, case fatality rates in generally have been low. So that's a very interesting phenomena, that in Asia and Africa compared to North America and Europe, case fatality rates related to COVID-19 have not been as high.
Thank you, Zulfiqar. Now I'm conscious of time, and I think we have time for one last question. So I just wanted to go back to a point that Bakri made earlier about the challenges we faced with community engagement and how this is impacting the population's perception of the health system and their care seeking. Bakri, do you have any examples of changes to health seeking behavior and ways in which MSF can sort of mitigate against any negative effects of this?
I think the big change in the health seeking behavior is it depends on the trust between the service provider and the communities we are serving. And I think there was huge mistrust during the COVID pandemic for many different reasons. Many people touched upon during these sessions. How we restore this trust, I think it's by more engagement of the community in the process of service delivery. In MSF, we do solidarity with communities. We don't do charity. And I think that puts the accountability on all the stakeholders, not only the provider. So the communities we are working with, in addition to the different stakeholders, the actors, the governments, and so on. So I would like to echo the message of the role of MSF in advocacy in different aspects, not only in the EPI or the vaccination, as Anne mentioned. I think it's very, very important, but also in the equity message that should be provided to different communities. And I think MSF has very strong role in this. We are backed with very good data. We work with the communities and in these communities and for these communities. And I think our voice can be heard very loudly on that. So I think we need to keep on with this message. It's very important and it's very pertinent for MSF to do so. My last message is also to continue with the self-critique we are very good at in MSF. And personally, I'm very much interested in the evaluation part. And I think this is really the right historical moment for MSF to change drastically the way we do evaluations of our interventions. Yeah, thanks.
Thank you very much, Bakri. And I would just like to say a huge thank you to all of the panelists. I've been so stimulated by this discussion. I think it's going to give our field team our field teams and the whole organization so much food for thought, for everything from how we design and evaluate our interventions right through to the role we have as advocates for the children that we work with. Yeah, it's been great, and thank you so much for your participation. I'm going to hand back to Anna now, who will give you the final wrap-up of this session. But I'd also like to extend a huge thanks to her and Liliana, Mona, Martin and Johan, who've worked really hard on bringing this session together. Thanks a lot, and we will try and get the questions that we were unable to answer in the chat. We will try and organise that directly with the people that have asked them. Over to you, Anna.
Thank you so much, Kim, for moderating the panel, and thanks a lot to the three panelists. It's been great, and yeah, we're always running out of time. So to wrap up this session about the collateral damage of COVID-19 on child health, I think I would like to share with you 3 points that I will include also some inputs that I was gathering during the rest of the session, no? Because COVID has been present during this edition. The first one, I think it's clear the importance that the role that MSF has to support and to advocate for the maintenance of the regular preventive and curative healthcare activities in order not to have an increase of mortality in the pediatric populations, because we have seen that the COVID as itself is not the biggest threat in this pandemic. I want to repeat again the sentence that Anne said, like about, she was talking about the collateral damage of the COVID-19 vaccines roll out. So let's not going to be focused only on the pandemic, but to be sure that we maintain all the rest of the preventive and curative activities that we know that they help in the reduction of the pediatric mortality. Also to keep practices that we know they work and they prevent a lot of deaths, as we saw yesterday, no, in the neonatal session, where they were saying that now more than ever we need to keep the babies and the mothers together. So in order to promote the breastfeeding and the skin to skin, that will prevent a lot of neonatal mortality. So, and it is something that we should keep in mind. The second maybe take-home message would be like that we have seen that a part of all the challenges that maybe we can face, I think COVID-19, this crisis can be always also an opportunity to implement new strategies to improve the activities that we are running in our context. And these activities at the end are going to have a positive impact on the child health. So we have seen examples from the field as the family MOAC implementation in White Nile. We have seen also other examples in other sessions yesterday, like for example, how we are working in simulation on remote in order to train the staff and to work with the staff to give them technical support, because we cannot do it now face to face. So this is a new opportunity. How we have now a simplified malnourished protocol. So because people are not going to the big health care centers for the management of the malnourished children. So maybe we have to be more centered at community level with the proper support, and to develop new tools, as Bakri was saying, for evaluating the impact of our activities. So I think each crisis can always be an opportunity, and this I think this is also a good example. And the third point I would like to have as a wrap up is, I think it's clear that for all this we need to be flexible and to be adapted to what the different challenges that are coming and that will come, because the situation is dynamic. So we will need to adjust our health activities. For this, I think it's very important, as the panelists were saying, the good collaboration between the different humanitarian actors. So I think it's also clear. And I think these were like the 3 main points that I wanted to share with you. I think we have arrived to the end of our session. I really would like to say thank you to everybody, especially to the participants. It has been super interesting. And that's it. Thanks a lot to everybody. And yeah, I think now Roberta Petrucci is going to do a wrap up of the edition. Thanks a lot.